it's my great pleasure to introduce to you Dr. Rob Welsh, who is a professor of medicine at the University of Alberta, Edmonton, Canada. Dr. Welsh is a world expert in the field of elevation myocardial infarction management, and would like to really to congratulate him on his great achievements and welcome him in our country.
Thank you very much. It's an honor to be here at the Saudi Heart meeting and to visit my friends and colleagues in the kingdom.
Thank you. Dr. Welsh, how do you rate your, what's your assessment and feedback about the conference itself? And if you can tell us a little bit about your talk in the fourth joint session between the Saudi Heart Association and the Canadian Cardiovascular Society.
So I've been very impressed at the conference. It's a very nice balance of international guidelines, international experts, local experts that have a very impressive wealth of knowledge, and then the realities of applying practice in this country with some of the abstract sessions. It's been an excellent meeting that's balanced across the different spectrums. The opportunity to collaborate with the Canadian Cardiovascular Society and the Saudi Heart Association has been an important collaboration. We're very proud of the work that you're doing. And we're also very proud of the collaboration. Many of our past trainees are in excellent positions and doing great things in this country. So that collaborative relationship between our two societies is key. The session that we held together that you chaired, really the focus of my talk was the reality of the new era. We've entered a new era of dual antiplatelet therapy where on top of the excellent outcomes we saw with aspirin clopidogrel over aspirin alone, we now have a new agent that actually showed enhancements over our best evidence-based aspirin clopidogrel regimes, the cure design plus higher loading dose if necessary when you go to the cath lab, and the new agent ticagrelor actually showed outcomes even on top of our best clopidogrel therapy, and the mortality advantage, which is the impressive difference. So we have a new step forward and a new opportunity to improve patient outcomes.
That's great. And could you tell us a little bit more about the lecture that you gave at the plenary session regarding the pharmacoinvasive approach?
The plenary session was an excellent session. I'm very honored to have been invited to present there. The pharmacoinvasive strategy is something that I believe strongly in for many years. Even when you were with us, we really focused on trying to apply care early in STEMI. And we tried to find the balance between mechanical reperfusion, primary PCI, and fibrinolysis early on in our STEMI program. We have huge regional issues, challenges with interhospital transfer just because of delays that are hard to negate. You can't remove the realities of having to call an ambulance to the hospital to then activate the system and transfer the patient from a community center to a PCI site. So the pharmacoinvasive approach now has been well established. In the STREAM study, we were very happy to see that the pharmacoinvasive strategy did as well as primary PCI. There's always been this debate about one versus the other, but in my opinion, it should never be a debate about one versus the other. It's the right therapy for the right patient, acknowledging the whole system, whether the patient is high risk, low risk, if they've presented early, presented late, and how fast you can deliver care. So I've always been a believer that the pharmacoinvasive strategy is our way forward if you can't deliver rapid primary PCI. In a tertiary care center like yours or like mine, we should be able to do primary PCI rapidly in every patient. That should be the first goal. But we do have to accept that that's not a reality for community hospital patients, for rural patients, for centers that don't have a cath lab on site.
You know, we had that discussion when we moved in our hospital in the last couple of years to a 24-hour 7 primary PCI program. And I remember that patient who presented at less than 12 hours, at less than 2 hours of chest pain onset. And I ordered my registrar to give thrombolytic. And I got all kind of criticism next day. He said, you know, we have a 24-hour 7 program. We understand that giving thrombolytic therapy very early can be as good, if not even better than primary PCI. But if you have a primary PCI program around the clock, we have to do every patient. I said, I'm sorry, but you know what? I'm here for the patient. I'm not here for the program. And here comes a discussion and negotiations and almost fighting now. Well, are you really supporting the program, or I argue, well, I'm here for the patient. So how could you get around that?
Well, the thing that I've personally found quite bothersome is that physicians have been led to believe that you're an inferior doctor if you give fibrinolysis, that there's something wrong with fibrinolysis. And it's completely not supported by the current evidence. If you look at who benefits from primary PCI, it's the highest risk patients for sure, if you deliver the care very rapidly. If you look at the 3/4 of patients that are not high risk and don't have high bleed risk, the two therapies are actually very similar, and we shouldn't feel guilty for doing what's best for the patients and delivering care based on where they arrive. Accepting those realities, in our tertiary care center, if they walk into our emerge, even though I know they'll get an excellent outcome with fibrinolysis, we do try to activate the cath lab and do primary PCI in all the ones in our tertiary care center. If they're one step out though, and they're in the ambulance and they presented earlier, then I actually lyse them in the ambulance because we've seen such amazing outcomes with early lytic. Obviously, if they aren't early or high bleed risk, then we activate the cath lab from the ambulance, and we've really got this balanced approach. And I think that's the best approach, and I think it's something that I wish our American colleagues would embrace. But there's such a drive to primary PCI that they're doing it almost against logic with the early presenting patient in a community hospital.
Yeah, I guess we as physicians, we kind of used to put it in another ways to say, you know what, I'm embracing this strategy and I'm just going full forward with it, and I don't want to go into exceptions on daily basis because that depends on how good you are in terms of being on call, and somebody else might not be as expert as you are, so he'll be doing something different. And I'm here as the head of the unit or the department. I want to make sure that I apply. I don't want to take all these into the game.
The challenge is mixed messages, which is what you're getting at. So an emerge doc or a frontline care provider sees a patient one day and is told has to be primary PCI, then a different attending is told, well, you can do this or do that. They get confused.
Exactly.
So the way we've gotten around that, which is challenging, and I'm not saying it's not labor intensive, is we've taken a small group of people that make all the decisions. So they're available by phone call, immediate decision making, and that's really helped our program. And it is one of the key points of why our program, I think, has succeeded, is we do apply the therapy with a small group of people that are rapid decision makers.
That's great. Well, Professor Welsh, any closing comments?
No, I'd just like to congratulate you on the presidency of Saudi Heart. It's an honor to be here, and I really congratulate you on the meeting.
Well, we're looking forward to actually join you on the upcoming Canadian Cardiovascular Society Congress that will be in the beautiful city of Vancouver at the end of October. I'm looking forward to have the 5th joint session between the Saudi Heart and the Canadian Society in Canada, and we're looking forward to have you again with us next year. Thank you very much.
Thank you. My honor.